Hello everyone, welcome back to Learn Anesthesia Basics. I'm Dr. Kavimita. Today let's discuss the most important complication which we see commonly in ENT surgeries, that is a bleeding tonsil. The bleeding tonsil occurs in 1 to 2% of all the tonsillectomies that we do. This bleeding tonsil or the hemorrhage can be classified as primary, reactionary and secondary. We call it primary when the bleeding or hemorrhage occurs during the operation, and we call it reactionary when it occurs within first 24 hours. Out of all the cases of reactionary hemorrhage, 75% occur in the first 6 hours and remaining 25% occur in the next 24 hours. We call it secondary when the bleeding occurs more than 24 hours and within 10 to 14 days. This secondary hemorrhage can be due to infection of tonsillar fossa and sloughing of the tissue, and reactionary hemorrhage is due to ligature slipping, dislodging of clots and opening of collapsed vessels. These are the types of hemorrhage, and let's see the anesthetic problems which we face during this bleeding tonsil. In bleeding tonsil, the most commonly we face problems like hypovolemia. This hypovolemia is due to swallowing of blood. There will be slow ooze of blood which the patient swallows, and it will take a long time for us to identify that there is a bleeding tonsil. So, by the time we identify this bleeding tonsil, there will be hypovolemia with tachycardia and hypotension. There will be orthostatic hypotension when 20% of the blood is lost. Next problem is full stomach. This is first, this is second. Full stomach can be due to food or swallowed blood. The next problem which we face is bleeding in upper airway. This causes difficulty in intubation. So while preparing the OT, we also prepare a large bore suction. It will be easy to intubate. The next problem which we face is previous recent anesthesia. What happens in this is there will be residual effects of narcotics and subglottic edema. The last and the main problem is shared airway with the surgeon. These are the few anesthetic problems which we face while dealing with a patient of bleeding tonsil. Let's see how to assess a patient. Let's see patient assessment. First, we have to take a proper history. Next, let's see the previous anesthetic record. In this, we have to concentrate on if there is any difficulty in intubation, what are all the drugs used, and what is the AT tube size that is used, and observation of the patient or examination of the patient for conscious level, pallor, and hydration level. Next, in examination, we look for tachycardia, any hypotension, and here we see for the AT tube size so that we can size down the AT tube while reintubating the patient. Next, how to resuscitate this patient. Resuscitation of this patient. In this, first we do IV access. Next, blood is taken for hematocrit cross matching so that we can transfuse if necessary. Third, we'll check for the coagulation. Fourth, fluid resuscitation with crystalloid, plasma, and blood. Transfer the patient in lateral position. And sixth, sedation. Do not sedate this patient heavily due to the fear of loss of protective airway reflexes. Now that we have shifted the patient to the OT, let's see how do we induce the patient. In induction, the patient is turned supine. We pre-oxygenate the patient. We transfer the patient in supine position. In pre-oxygenation, vital capacity breaths are avoided in patients with blood or secretions in the mouth. And we do rapid sequence induction with cricoid pressure. We use ketamine if in case of hypotension and hypovolemia, and scoline or rocuronium in case of full stomach. While taking an endotracheal tube, we use a 0.5 to 1 mm smaller size than the previous ET tube. Next, NG tube to remove any swallowed blood. Next, we give steroids. So the steroids like dexamethasone 0.1 mg per kg to decrease airway edema and also as an antiemetic. Maintenance is by positive pressure, intermittent ventilation, and non-depolarizing muscle relaxants. Emergence or extubation to be done in lateral position. Extubation to be done in lateral head down position or supine head down position. Always extubate the patient in fully awake state. Post-operatively, the patient is shifted in tonsil position. In tonsil position, the body is semilateral, 45-degree forward inclination, upper arm is under head, no pillow under the head, lower leg straight and upper leg is bent. This is the tonsil position. That's it for today. Thank you for watching. Please like, share and subscribe.